A Physician's Brief, The Great Divergence, How Hospital Administrators Captured American Healthcare, while Physicians Were Left Behind, Income, Headcount, Power, 1940 to 2026. A primary care physician said this in 2026. The physician spends 11 years training to save lives. The administrator gets an MBA and within a decade earns 3 times as much. The numbers you are about to see are not opinions. They come from IRS public filings, from Bureau of Labor Statistics data, from CMS records and peer-reviewed journals. They have simply never been put in one place before. Until now, 4 numbers. Before we go further, 3,800%. That is how much healthcare administrator headcount has grown since 1970. Physicians grew 200% in the same period. 12 to 1. That is the ratio of nonprofit hospital CEO pay to average physician salary in 2026. $2.4 million. That is the annual income gap between a nonprofit hospital CEO and a primary care physician at a hospital claiming tax-exempt charitable status. Negative 29%. That is the real, inflation-adjusted change in Medicare physician reimbursement since 2001, not zero. Negative 29. These are not projections. They are documented outcomes. Each one is sourced. Each one is real. In 1940, a physician earned approximately $3,000 per year. The hospital administrator earned about $5,000. Here is the important part. The administrator existed to support the physician, not to override the physician, not to approve the physician's clinical decisions. The hospital was, in the language of the era, an open workshop, a facility physicians used to treat patients. The physician ran everything. The administrator handled billing and scheduling. The ratio was approximately 1.5 to 1. The administrator earned slightly more in salary. The physician had all the power. Both of these things were about to change. One faster than anyone expected. 1965. Medicare and Medicaid are enacted. Before this moment, billing was simple. A physician saw a patient. The patient paid. There were no codes, no prior authorizations, no compliance officers. After this moment, billing became a federal enterprise. Medicare required claims submissions, diagnosis codes, reimbursement negotiations, compliance audits, documentation standards that no physician practice could navigate alone. The administrator was no longer a convenience. The administrator was, suddenly, a necessity. And where there is institutional necessity, there is institutional power. This was the seed. The tree it grew from took 50 years to cast its full shadow over every physician who came after. Between 1970 and 2024, the number of practicing physicians in the United States grew by approximately 200%, roughly matching population growth. In the same period, healthcare administrators grew 3,800%. Let that number sit for a moment. 3,800%. For every 1 administrator in 1970, there are now 39. There are currently 10 administrators for every practicing physician in America. The money required to pay those administrators does not come from somewhere outside the healthcare system. It comes from the system itself, from the insurance premiums you pay, from the Medicare taxes withheld from your paycheck, from the hospital bills that are now the leading cause of personal bankruptcy in the United States. Here is the full record, 1940 to 2026. In 1940, physician $3,000, administrator $5,000, ratio 1.5 to 1. In 1965, when Medicare passed, physician $28,000, administrator $30,000. Still rough parity. By 1990, the ratio had reached 2.1 to 1 in the administrator's favor. By 2000, 3.6 to 1. By 2005, 7 to 1. By 2015, 10 to 1. By 2026, physician, $374,000. Hospital CEO, $3,800,000 and more. Ratio, 12 to 1. This is not a natural law. This was a choice, a series of choices made by hospital boards, by policymakers, by compensation consultants, and by the institutions themselves. Between 2005 and 2015, the divergence became permanent. A peer-reviewed study published in PubMed Central analyzed IRS Form 990 data from 22 major nonprofit medical centers. The finding was straightforward. In 10 years, major nonprofit hospital CEO compensation rose from $1.6 million to $3.1 million. That is a 93% increase. In the same 10 years, physician salaries rose 10%. Here is something that does not make the news. In 2001, Medicare paid physicians 100 cents on the dollar for their work, by CMS's own index. In 2026, after 25 years of annual fee schedule updates, that same payment is worth 71 cents, a 29% real decrease in what a physician is paid for the same unit of clinical work. In the same period, hospital CEO compensation rose from an average of $700,000 to $3.8 million. The same system. One side going up, one side going down. For 25 years. Without pause, the majority of American hospitals, including the largest, most profitable systems in the country, are tax-exempt nonprofit organizations. They pay no income tax. They pay no property tax. They receive charitable deductions on donations. The legal justification is that they provide community benefit that exceeds their tax burden. Between 2010 and 2021, nonprofit hospital systems across the United States paid their top executives more than $1.75 billion in total compensation. $1.75 billion. From institutions claiming charitable status. Studies consistently find that the tax benefit received by major nonprofit hospital systems exceeds their charity care spending. A nonprofit that pays its CEO $3.8 million per year, while primary care physicians in its network earn $287,000, is not a charity. It is a corporation with a tax exemption. More than 60% of U.S. physicians report symptoms of burnout. The healthcare system's answer, for most of the last decade, has been meditation apps, wellness committees, mindfulness seminars, resilience training. This is not a resilience problem. The drivers of physician burnout are documented and structural. Administrative burden, prior authorizations, EHR documentation, compliance requirements, consumes more than 4 hours of every clinical workday, generating no patient value. Loss of autonomy. Clinical decisions now require administrator approval. Formulary restrictions override physician judgment. Algorithms deny care ordered by a physician who has spent 11 years training to make exactly that judgment. Compensation stagnation. Real physician income flat or declining for 20 years, while the cost of training, practicing, and living has risen. And moral injury, the experience of being unable to deliver the care a patient needs because an administrator decided it was not cost-effective. These are not personality problems. They are the predictable results of a system reorganized to serve administrative interests over clinical ones. The United States faces a projected shortage of up to 86,000 physicians by 2036. The standard explanation is that medicine is simply not attractive enough as a career. Let us look at the economics. A medical graduate today carries an average of $250,000 in student loan debt. After a 3 to 7 year residency, earning $60,000 to $80,000 per year for 100-hour weeks, they enter practice in their early to mid-30s. A primary care physician earns $287,000 per year before taxes, before malpractice insurance, before loan repayments. The administrator who manages that physician earned $3.8 million. No nights on call. No malpractice exposure. No decade of postgraduate training. The pipeline is not failing because students are uninterested in medicine. It is failing because the system has made medicine an irrational economic choice for the people most qualified to practice it. The average American physician spends 14 hours per week on prior authorization. 14 hours per week, per physician. 1 million physicians in the United States. That is 14 million physician hours. Every week. Gone. Into a paperwork process that has never been shown, in any clinical trial, to improve patient outcomes. Prior authorization requires an insurer's permission before a physician can prescribe a medication they have determined is necessary, order a test they have determined is necessary, or perform a procedure they have determined is necessary. The physician spent 11 years training to make exactly that determination. The administrator who reviews and often denies that determination has no medical training. Prior authorization exists to deny care and reduce insurer costs. The administrative staff required to manage it are part of the same administrative layer this report documents. 14 million hours per week. Into a system that produces no care. The United States spends approximately $12,600 per person per year on health care. Germany spends $7,100. Canada, $6,000. The United Kingdom, $5,300. The United States spends nearly twice as much as the next closest comparable nation. The United States ranks 37th globally in health outcomes. Germany ranks 4th. The administrative layer in the United States accounts for an estimated 15 to 25% of all healthcare expenditure, the highest proportion of any developed nation. Every other comparable country spends less on administration. Every other comparable country achieves better outcomes. The money is not missing. It is in the administrative layer. 5 questions that have not been answered. 1. Why is Medicare physician reimbursement falling while administrative costs rise? The money is in the system. Why does it flow to administration and not to the clinicians delivering the care? 2. What community benefit justifies a nonprofit CEO earning $3.8 million at a tax-exempt institution? The IRS should be asking this question. 3. Why does prior authorization exist in its current form when it has never been shown to improve patient outcomes in a clinical trial? 4. When will medical education debt be proportionate to physician compensation? An economic proposition that requires $250,000 in debt and a decade of low-wage training to access a career of declining real income is a broken proposition. 5. Who is accountable for patient outcomes? The physician carries the accountability and earns the least. The administrator carries the least accountability and earns the most. This asymmetry is not sustainable. 5 changes. None of them require dismantling the system. Reform Medicare reimbursement. Reverse the 29% real terms decline since 2001. Scrutinize nonprofit CEO pay. Require public comparison of executive compensation to median worker and physician pay at every tax-exempt institution. End unnecessary prior authorization. If a prior authorization requirement has not been demonstrated to improve outcomes, it must be eliminated. Reform medical education finance. Loan forgiveness for underserved specialties. Income-driven repayment reform, and government-funded residency expansion. Restore physician governance. Place clinicians on hospital boards with real authority over clinical and operational decisions. These are not radical proposals. They are the minimum conditions for a system that takes seriously the claim that it exists to deliver care. The physician is not asking to be made wealthy. The physician is asking for a system in which the work is valued in proportion to its difficulty, its importance, and the years required to master it. A system in which the person who saves the life earns more than the person who manages the budget of the institution where the life was saved. A system in which training does not begin with a debt that takes a career to repay. A system in which clinical judgment is not overridden by an algorithm operated by someone who has never seen a patient. The outrage in this document is intentional. It is also proportionate to the documented facts. Documenting the injustice is the first step toward ending it. All data in this presentation is sourced from the Social Security Bulletin, 1950, CMS, Healthcare Financing Review, AMA Physician Practice Benchmark Surveys, Medscape Physician Compensation Reports, a peer-reviewed study in PubMed Central on the Executive Physician Wage Gap, 2018, PLOS 1, 2024, Health Affairs, 2024, a joint report by the North Carolina State Treasurer's Office, Johns Hopkins, and Rice University, 2023, Physicians for a National Health Program, the Doximia Physician Compensation Report, the Commonwealth Fund International Health Policy Survey. The full-sourced brief is available as a separate document. There are now 10 administrators for every physician in America. The United States spends nearly twice as much on healthcare as any comparable nation, and ranks 37th in outcomes. These two facts are not unrelated. The Great Divergence. Physician income versus hospital administration. 1940 to 2026. Daniel Rusu, M.D.